Hi, my name is Mary Vukicevic, and this lectorial is about the low vision management strategies for patients with severely constricted visual fields. You should already be familiar with the case of Lionel. Lionel is 45 years old and he was diagnosed with retinitis pigmentosa about 15 years ago. It is progressively worsening and he's arranged an appointment at Seawell Australia to explore his options. And one of his biggest concerns is that he's still in the workforce, so he wants to remain commercially viable. So through Lionel, you will develop an understanding of the appropriate low vision rehabilitation for a patient with severely constricted visual fields like he has. So essentially he complains of decreased peripheral vision, night blindness, problems with light-dark adaptation, and consequently he's also having problems with mobility. His referring ophthalmologist has indicated that he's got typical retinitis pigmentosa changes on his fundus. And you'll remember back from the pathology subject that the signs that you see on the fundus of a patient with retinitis pigmentosa include this bone spicule appearance, which is the retinal pigment epithelium, or rather pigment. And you also see the attenuated arterioles. As you can see here, they're quite thinned out. And the third sign is the waxy appearance of the optic disc. So this is his left eye, and the appearance of his right eye is very similar. All right, so you see Lionel for the first time, and the findings from your initial consultation are shown here. So his general health is good. He's not on any medications. He has worn glasses since he was a teenager, and you can see that he's got a mild myopic prescription, and he wears single vision distance glasses. His vision with those glasses is 6/12 in the right eye, 6/9 in the left, and his near vision with both eyes open is N5, but he reads slowly. He takes his glasses off to read is the note that you've made there. Now, why would that be? Why would he take his glasses off to read? Have a think about why a 45-year-old with that sort of prescription would want to take his glasses off to read. That should be pretty evident to you at this stage of the course, so I'm actually not going to answer that question. If you don't know, you need to go and find out. Subjective refraction shows that with a little bit more minus, he can improve to 6/9 part in the right eye, but there's no change in the left eye. And a +1 add gives him N5, and that's when you introduce a light and let him read with both eyes open. Pelly-Robson contrast shows a finding of 0.9, which is moderately reduced contrast. And City University colour vision test shows non-specific colour vision loss, but leading towards the tritan zone. Why is that? That's another question. Why does he have tritan loss, and what is specific about tritan loss? We'll think about those questions a little bit later on. And then on the right-hand side, you'll see the grayscale of his Humphrey visual fields, which is showing a constriction in both eyes to within 10 degrees from fixation. Now, as part of Lionel's full case, you've got the full interpretation of the full output of the Humphrey visual field, so you can refer to the numbers and the other important factors on his visual field, not just the grayscale. All right, let's start talking about what peripheral vision is and the basic functions of peripheral vision. So the key to rehabilitation of patients with peripheral loss is to understand that there are 3 basic functions of peripheral vision. 1 is organisation of visual scanning. 2 is the visual warning system. And 3 is night vision. And you can see the illustration here shows a scene with normal peripheral vision, and then the peripheral vision constricted there on the right hand side, and you can see what effect that has on the vision of a person. The peripheral system is integral in helping us to organise what we call visual scanning. So when someone with normal eyesight and a normal visual field looks at a scene such as a face, as we see in this example, they make several saccades which help to orientate themselves to what they're looking at. And these lines are indicative of the saccade pattern when someone's looking at this particular face of a girl. So each saccade will end with a very small fixation which lasts less than a second, milliseconds, at each point that they're looking at. So you can see where this particular person has looked at the image of the girl. What they've done is they've looked around, but they've spent a lot of time fixating on the eyes and on the mouth and also on the hair. So they're spending a little, wherever there's a dark spot indicates they spent a bit more time looking at that area. So what then happens is the visual system will piece together each of those fixations and saccades to get an overview of the scene of what the person is looking at. That's what happens when you have normal eyesight. Obviously, this whole system becomes affected when you've got decreased peripheral vision. So in normal visual function, the second function of peripheral vision is the use of the periphery that we're seeing as a warning system. And this is crucial when we're driving, walking through crowds, or in the example of the picture shown here, trying to cross this very busy road full of people, full of cars, full of lots of activity. We're using our peripheral vision to orientate ourselves to this zone so that basically we don't get run over by a car. So the peripheral system is a warning system. And then the other function of the normal peripheral system is our ability to see at night time. The peripheral retina, again, you should already know this, is most sensitive under scotopic conditions, more so than under photopic conditions. So loss of peripheral vision leads to night blindness and difficulty adapting when the lighting conditions change, so going from light to dark or vice versa. And that's one of the complaints that Lionel had. All right, so how can you help patients with severely constricted visual fields like Lionel? Eye diseases that affect the retina, such as retinitis pigmentosa, and that lead to that sort of tunnel vision that we see with Lionel, usually come on gradually. It's unusual for it to happen quickly. So this does give the patient some time to adapt, but often you'll still need to teach them compensatory scanning. How do we do this? Well, we start with a simple scanning exercise, and we put an object on a clear table, a table that is uncluttered. And in this example, I've got just a little yellow toy which is on the table there. It'd probably be better to actually put an object there to start with that's better contrast than this yellow toy on the light brown table. You might want a red toy, something that stands out a little bit better actually. So what you then do is you seat the patient there and you ask them to search by moving their eyes to sweep across the table, so making a sweeping movement left, right, up and down until they locate the object. And you can start with big objects that are bright and high in contrast, and then you can eventually move down to very, very small objects, placing a little bead or something like that that's low in contrast, and they look around for that as a higher end activity. So that's one way to start very simple scanning training. And family members of these patients can get involved in that too. They can practice this at home. It doesn't have to necessarily be in the clinic. You can follow up the simple scanning exercise with a more complex task. And what I like to do is I just take an A4 sheet of paper and draw up this scanning training exercise that's shown here. So what happens is the patient will start, well, they'll fixate on the word start, and then they'll follow the line across until they get to number 1, and then number 2, number 3, and so on. Now, don't make the mistake that I've got here and put 2 number 3s. Try and make it a sequence, and that should be 4 and 5 and so on. So you can just draw this up on an A4 sheet and give it to them to take home. It's a very easy way to practice scanning. You can also adapt the scanning training and give it a distance element as well. So you just need a bit of wall space, either in the clinic or in the patient's home. And they sit down or stand, it doesn't really matter. And you stick some letters on the wall, nice big ones so they can find them, about 1 metre apart or so. And the patient scans from one letter to the other. You should try and actually do these yourself, and you'll see, you know, create a bit of tunnel vision by closing one eye and holding your hand over the other to give you a bit of tunnel vision, and see if you can practice these tasks and see what it's like to actually do some visual search and visual scanning. Another option, if you happen to not work in the rehabilitation setting yourself, but you're in an ophthalmic clinic, you can refer to an external service that will provide the scanning training for you. And I've given you the link here to Guide Dogs Victoria, and they have an acquired brain injuries service. And you can see there that some of the things that they teach the patient is scanning to compensate for visual loss, increasing awareness of the functional vision loss, transferring training strategies from indoor settings to increasingly challenging environments, and they suggest shopping areas and so on, road crossing strategies, use of public transport, problem solving, planning, and other cognitive skills. So it's a very good service, and it's definitely something that that you can refer patients to. That link there gives you an idea of exactly what the service entails and how to make a referral. And orthoptists are welcome to make this referral. It doesn't have to come from anybody else. You can actually do the you can actually refer your patient to the service. Okay, so your next task is to read this article by Peter Hurst, and after you've done that, you can answer the questions related to Lionel's case, because this lectorial together with that reading helps to inform those questions for you. On a final note before I end this, the training techniques I've mentioned here can also be applied to patients with acquired brain injuries and other neurological problems. So, for example, things like hemianopias resulting from a stroke. And in the next case study, I'll be expanding this further. Okay, good luck.